Good morning, Chairperson Srivastava sir and Basu sir, and good morning, everybody. Greetings from Medanta. I'd like to thank my friend Dr. Basu for the kind invitation. I will be discussing on algorithms, motion management, collimators, imaging workflow because nothing much there for the platform, but still I will try to cover. Whenever we talk about the lung SBRT, the first trial which comes to the mind is RTOD 0236, which did not use heterogeneity corrections as illustrated by Dr. Anil. So Zayo et al. Did a dosimetric evaluation of this trial, and they found that the mean dose to the PTB was 55 gray, not 60 gray. And they also found, I think this is cutting, the non-heterogeneity correction algorithm, they overestimate the dose to the target and underestimate the dose to the OARs. So that is very important. Overestimation of dose to the target, underestimation of the dose to the critical structures. So similar observations were made in this paper which compared pencil beam versus Monte Carlo, and they found that pencil beam algorithm overestimate the dose. So that means actually the dose delivered is lesser in the target. And they overestimate the dose to the OARs. Underestimate the dose to OARs, overestimate to targets. So conformity index, RTOG conformity index have a lot of fallacies discussed, but still it is PIB upon PTV. Gradient index is 50% dose upon the target volume. From RTOG 0813, all further trials, they have necessary to use the heterogeneity correction. And this was reflected in the dosimetric criteria, as you can see. So they have relaxed these because the previous non-heterogeneity correction algorithm were underestimating the target. So actually in practical, they have taken this in practical consideration. So they have relaxed these criteria, as you can see in these boxes. And about the algorithms in different platform, the CyberKnife is using the TPS of precision, which has two algorithms. One is ray tracing, other is Monte Carlo. The Electra setups, they are using Monaco, which is using the Monte Carlo. The variant setups, the Eclipse is using two algorithms, AAA and across. Type A algorithms, Type B and Type C. Type A algorithms, they are mainly example like Pelson beam, TAR, Batho. They overestimate the target dose, as we have seen in RTOZ 0236. Then is Type B is convolution, superposition, collapse cone, AAA. They have improved accuracy, but still many studies have shown there is a 3% difference with the gold standard, that is Monte Carlo. But some authors, they have also reported that the difference might be up to 10% also. And type C algorithm one is across used by the variant systems. This is based on the Boltzmann linear coefficient transport. And the other is Monte Carlo, which is the standard Monte Carlo is a full-fledged Monte Carlo, is very slow, very lengthy. So the commercial systems, they have made it faster by using up to 4 decimal places. So that is faster. So the Monte Carlo, commercial Monte Carlo means a shortened Monte Carlo as in contrast to the full-fledged Monte Carlo. So this is a very nice article which tells about for the physicians using different algorithms. So you can go through this. So the type B algorithm, superposition algorithm, was compared with Monte Carlo in this article using the criteria of 0813. They have found that the type B algorithms, they underestimate the intermediate dose, as we have seen in type A also, but to a lesser extent. So in this same study, the Monte Carlo recalculated plans, they could not meet the criteria, as you can see in the yellow boxes. So that means more relaxation was required for the Monte Carlo. So, and this was also taken into account the Rosal trial. So that means the superposition or type B algorithm were underestimating the intermediate dose and overestimating the dose. This is the comparison between type B and type C algorithms, as you can see, and they concluded that the type B algorithms, which was better than type A, but still they underestimate the target dose, overestimate the intermediate dose. These two studies, they compare, and there are many other studies also, they are comparing different algorithms. Type A, type B, type C, type C, Monte Carlo, and across also, which is very close to Monte Carlo in accuracy. So they have concluded that type C algorithm should be used in lung SBRT planning. And all these studies were regarding the lung SBRT. But across was fastest compared to Monte Carlo. the SABR consortium, they advocate, which is a very recent one, at least type B algorithm for lung SBRT, or preferably a Monte Carlo or across. And this paper compares two algorithms used in CyberKnife. One is the ray tracing, other is the Monte Carlo. So you just focus on the red box. You can see with ray tracing, there is a 20% overestimation of the dose, 20%. That means for prescription of 16.5, there is a 10 gray overestimation. That means actually the 10 gray less dose is delivered with the ray tracing as compared to Monte Carlo. So the authors, they recommended that ray tracing should not be used in CyberKnife for lung SBRT planning, and especially in the peripheral tumors. Now coming on to the collimators from different vendors, the CyberKnife is using cones from 5 millimeter to 60 millimeters and iris. The 5 millimeter cone at the 80 centimeter is 3.85, but minded that is used only for a trigeminal path. Otherwise, in all other paths, you use 1 meter or 100 centimeters. The MLC thickness of Versa is 5 millimeters, 2 beam and edges from high definition MLC from 2.5 millimeters to 5 millimeters. They are Millennium and SD. I will not go into detail of these collimators, but we all know thinner collimators or finer collimators increase the conformality of a plan. That means micro MLC, they increase the conformality, but that is important in less than one, the target volume is less than 1 cc. So this is more applicable in case of cranial SRS, but what about in case of extracranial SBRT, lung SBRT, where we have the target volumes more than 20-30 cc's. So practically implications are lesser. So there is an Indian article which compared 5 mm MLC versus 2.5 mm this high density SD MLCs. They found that both these were able to satisfy the dosimetry criteria. So not much of practical implication for the lung SBRT, the final. So even a 5 MLC is okay, 5 millimeter MLC is okay for lung SBRT. In fact, improvement in the conformity, which we are talking with the finer MLCs, they may actually be a detrimental. A conformity index of less than 1 might be detrimental. Why? There are two articles you can see. The first one has shown that if the conformity is more than 1.1 as compared to less than 1.1, there is an improvement in the local control, metastatic control, overall control, survival. With the higher conformity, that may sound slightly that poor conformity is having improved control. In the second trial published in the Green Journal, the authors, they have shown that if there is a very tight conformity of the plan, the 2-year distance metastatic rate was 60% versus a very lesser conformal plan having a 5%. So they suggested a caution for the radiotherapy planning with steep dose gradient. So the reason is when we are using a slightly less conformal plan, there is a like in this red circle, the grays, the mark zone that is going to eradicate the micrometastasis. So a very tight conformal plan might be detrimental. And now comparing about the this is the triple F beams. All systems Edge, 2 beam, Versa SD, they are using, and CyberKnife, they are using a triple F beam with a dose rate of 1400 for the Electra and Variant at 6 MV, and for CyberKnife 1000 centigrade per minute. So triple F beams, they improve the dose distribution. Not improve, it is comparable with the flattened beams, but the time duration is shortened, which might have implication on comfortability of the patient. But it is a double-edged sword because the patient might move that have a more dosimetric implication. And 6 MV improve conformity as the shallow depth only. And the 10F, they have slight improvement in screen doses, but of irrelevant clinical implication. But the control rates of triple F versus flattened beams are equal. SABR recommends, the consortium recommends triple F beam preferably. And what about the couch rotational errors? All these Edge, 2 beam, Versa SD, CyberKnife, they are using 6D correction, tomotherapy, and the Radizag, they are using a 4D correction. Does it have an impact on lung SBRT? Yes, in case of brain SRS, because a minimum safety margin of 2 to 3 millimeters should be taken if no rotational error is being corrected. And there would be a lack of coverage of those almost to the tune of 3%. But does it have an impact on lung SBRT? Let's see. These papers, they evaluate the different degree of rotational errors versus the dosimetric effect. they found that up to 5 degree of rotational errors, which is not being corrected, they can be only less than 3% of dosimetric difference. So practically, for a peripheral lung tumors, not much important, but in case of central lung tumors, yes, if we have correction, 6D correction, that would be preferred. And now about the NC beams, non-coplanar beams, there would be a definite dosimetric advantage, but it won't be translated in the clinical outcome in terms of using a non-coplanar beams. But sometimes, yes, in case of central lung lesions, ultracentral. And all these systems, as 2-beam, Versa SD, and Cyberknife, they have the possibility of using a NC beams. What about the intrafractional imaging in different setups? Real-time imaging with fluoro is yes in all those systems, comparing as 2-beam, Versa, Cyberknife. CBCT, yes in all except Cyberknife and tomotherapy and Radixact. We cannot do intrafractional imaging, yes in all. 4D CBCT, yes in all except Cyberknife, whereas the 2D imaging are there on orthogonal planes. Real-time tracking, yes in all. Clarity in Versa SD is used for the prostate motion, but not for the lung. Deformable registration present in all. And this slide shows the dose delivered in these intrafractional imaging. This is a survey of NRG oncology survey in which 36% of the users, they were using only the ITV strategy for lung SBRT. And around 25% were using either gating, breath hold, or tracking. And this lower down article, NRG, this is an NRG review on SBRT. Important take homes are residual motion should be included in the ITV, even if you are using a lung respiratory management. Coaching is very important. It improves the correlation between the internal anatomy, that means tumor, versus the external surrogate. Treatment on end expiration is more reproducible, but patients are less compliant, and better sparing of structures in end inspiration scans. This breath abdominal compression can be used in any of these except Cyberknife. And the RPM Exatrack is used in variant system, which uses, discussed previously, uses the 4D CT, and there is an administration of radiation within a particular phase that is called gate. I will not be going in detail in this. So there is one problem with this is there is a phase shift. Phase shift is when there is a dysynchronization between the tumor motion and marker motion. The surrogate markers. So that means beam is delivered at a different phase. So out of sync treatment, you can see. So there are ways how to check this. And other is the interplay between the MLC motions and the respiratory movement of the tumor and OARs. This can lead to a gradient effect and the interplay effect, which is very beautifully described in this AAPM articles. This gradient effect is more detrimental in SBRT. On the right side, you can see this is the static image, and the right side is the motion images. They can be at missing of the target with the gradient effect.
2 minutes are left.
In the Electra setup, we have got the DIBH with ABC, where the spirometer is attached. Patient is trained in 2 or 3 days to take a definite amount of volume in the air, depending upon his comfortability, and to hold it amount of duration where he can be comfortable and we can deliver treatment. This is a very robust system. And if your training is not accurate, there can be a mismatch between 2 inspiratory breath hold images. So training is very important. As you can see in the lower panel, 2 images are matching perfectly. Even the cavities, they are matching perfectly. This is because of good training. But 15% of the patients, they are non-compliant for the ABC. They can be tracheostomy patient, that is the issue, cannot be done. COPD patient, edentulous patient, anxious patient, they can be done. They cannot all do the ABC. But we have reported a case where we did a tracheostomy patient ABC, and then we subsequently we have done 2 or 3 more cases with this ABC. And target tumor tracking is 1 minute. Tumor tracking with synchrony system. In this, there is surrogate marker kept over the abdomen, which is going to form the respiratory model. And at the same time, 2 X-rays, orthogonal X-rays, they are going to track the tumor. And at different point of respiratory cycle, the tumor is imaged. And then a correlation model is formed. First, it will tell whether both the cameras can see. Like in this image, both the cameras can see the tumor. It's called the X-side lung 2 view. If one camera cannot see because of the scapula or vertebra, then it's called 1 view. So we have to give a ITB in the perpendicular direction to the camera, which we cannot see one view. And so this model, so a correlation model is created where the respiratory cycle is correlated with the location of tumor in two view, and then radiation is delivered. So this model predict the position of the tumor at different phases of respiration, and the radiation is delivered. So that was the last slide. So this is our team. Thank you so much.
Thank you, Dr. Shyam. It's nice presentation covering all the machines. I think, as we said, that we'll have the question at the end. Keep your questions ready. The last